pain relief. Sir has a diploma in palliative medicine from India and Cardiff and a master's in palliative medicine from Cardiff and a very extensive 15 years of experience in palliative medicine. The clinical services, academics, and research wing of Pallium India are overseen by Dr. Sunil Kumar. So, sir, it is over to you for the day to walk us through the most important topic, methadone.
Thank you, Mr. Priya. Good afternoon, everybody. So, this is the last session, and we'll be talking newly available medicine in India. Not newly available, it is available for the last 2-3 years now. So, what we are looking at is methadone is different from other opioids. So we will look into the details of pharmacology of methadone. And some of you might have heard about the risk and benefit of methadone. So we'll be looking into that also. Then the usual question is when we start methadone, how should we monitor the patient? So that's also important. Then some of the doctors know or they have attended the methadone classes, but even they have a methadone with them after finishing the class, but they are not sure for whom they should start methadone. So we will look into that. And most importantly, we need to know how to convert an opioid to methadone. So this is a usual situation which you will encounter, and there are various methods. Okay. So first of all, let's go into the pharmacology of methadone. So methadone is a isomer of S-methadone and R-methadone. We know that opioids act by acting on opioid receptors, mu, kappa, or delta. But can anybody tell me which opioid receptor agonist is morphine? Anybody? Which is the receptor on which morphine acts as agonist?
It's on mu receptor, sir.
Yeah, it's mu receptor. And the most fentanyl, morphine, tramadol, all these are mu opioid agonists. But in case of methadone, it acts as an agonist on all opioid receptors, mu, kappa, and delta. And methadone is also an NMDA antagonist, that is N-metyl-D-aspartate antagonist. Which is the other NMDA antagonist which you know?
Ketamine, sir?
Yeah, it's ketamine. Yeah. So methadone has that property also. Then it also acts as, it inhibits the reuptake of noradrenaline and serotonin. Which group of medication have this property? Which other group of medication?
5-HT3 receptor antagonist, sir. Then tricyclic antidepressant.
Yeah, it's tricyclic antidepressants. 5-HT3 mainly it's serotonin, isn't it? Tricyclic antidepressants, it inhibits the reuptake of noradrenaline as well as serotonin. So methadone also acts like a tricyclic antidepressant. And you can see in addition to this, so the first three which I have already told now, they are actually beneficial in the pain management. The last one, you can see it also acts on HCRG. HCRG means human either agogo related gene, which is a type of gene available in smooth muscles and it is most abundant in myocardium. So when methadone acts on HARG, sometimes it can produce prolongation of QT interval, which will lead to torsades and ventricular arrhythmias and sudden death. So that is one of the disadvantages or risk involved with methadone. So the first three are beneficial effect, whereas the last one is it is a disadvantage. So let's look at various advantages on acting on various mechanisms. So when opioids, methadone acts as an opioid receptor agonist by acting on mu, kappa, and delta. As you know, it will give analgesic effect. But in addition, it can also produce the side effects, which is common with other opioids. So sedation, constipation, urinary retention, edema, etc. And it also acts on NMDA antagonist. So you can see here there are 4 patients, patient A, B, C, and D. And on the x-axis, it is the dose of morphine equivalent they are taking. So the first patient D is taking about 1000 milligram per day, whereas C about 3000 milligram, and B 8000 milligram, A 12,000 milligram of morphine per day. And all these patients were converted to methadone, and all of them was started with 10 milligram 8-hour day. That means the total 30 milligram. A, B, C, and D started on 30 milligram, regardless of what the dose of morphine was, and all of them has got good pain relief with 30 milligram of methadone. So this is probably due to the tolerance developed due to opioids. And can anybody tell me what is tolerance?
So that is when the same dose that we are using on the patient, it is not giving this clinical effectiveness that we desire of.
Yeah, thank you. That's it. So suppose a patient who is on 10 milligram morphine today is getting good pain relief, but after some time, the patient needs more dose, maybe 20 milligram, to get the same pain relief. And after some time, it will go on. And probably these patients are taking this much morphine because of the tolerance they develop. And NMDA and NMDA receptor is one of the mechanisms involved in tolerance. So when all the patients are given 30 milligram of methadone, they got good pain relief. And this is probably because it has an NMDA antagonistic action also. So this is one of the advantages. And you know that NMDA, because of NMDA antagonism, it is also useful to treat neuropathic pain. So the first advantage was on acting on opioid receptors, and second one was due to NMDA antagonistic action. So it prevents and reverses the tolerance. And third advantage is, as you know, it acts like a tricyclic antidepressant. So it will be having benefit in treating neuropathic pain. But it can also produce something called as serotonin syndrome. This is not only specific to methadone, but it can be even produced with tramadol, because you know tramadol also tramadol has dual mechanism action. One is it acts on mu opioid receptors, and the other is it also acts as a tricyclic antidepressant. So here methadone, when you give it along with the medications like SSRIs, it can produce serotonin syndrome. And you can see there are many medications like fluoxetine, sertraline, paroxetine, many things. And these are divided into medications which has high probability of producing serotonin syndrome, medium probability, and low possibility. So, how do you recognize serotonin syndrome? So, if a patient has serotonin syndrome, the patient may have cognitive changes, autonomic instability, and neuromuscular changes. So, the patient may be agitated, restless. The temperature will be increased. There will be tremors, cogwheel rigidity, seizures, etc. So, if a patient is on methadone, and suppose you add some tricyclic antidepressants or SSRI along with methadone, and if they have agitation, increased temperature, tremor, think of whether it is due to serotonin syndrome. I haven't seen any patient with serotonin syndrome, even though our experience is limited to 2 years with methadone use. So the last action of methadone was action on human either agogo related gene, which we have already discussed. So it can increase the QT interval, and it can lead to torsades, which can lead to ventricular arrhythmias and sudden death of the patient. So there are some risk factors associated with the production of torsades, and these are electrolyte abnormalities, especially potassium, calcium, and magnesium, and old age, female gender, structural heart disease, genetic predisposition. So you can see there are many. Malignancy is one of them, peptic ulcer disease, and high doses of methadone, that is more than 45 milligrams per day. So all these are risk factors for producing torsades. So when you select the patient, please see whether the patient has any such risk factors, which will add to torsades. But even though many people fear about torsades, the most of the studies on methadone was on people who are using methadone as an substitution therapy. So methadone is not only used as an analgesic, but it is also used as an substitution therapy for opioid use disorder. So most of these patients will be on hundreds of milligrams of methadone. So when the dose of methadone increases, the chance of increasing the QT interval is more. Here is a study conducted by MD Anderson Cancer Center, and they have monitored the patients with ECG at baseline, and again at 2 weeks, 4 weeks, and 8 weeks interval. And the median methadone dosage was 23 milligrams. And they couldn't find out any significant ventricular fibrillation or any patient dying because of methadone. So this is one study from which we can assume that if you use low dose of methadone, that may not produce a significant QT interval prolongation, which leads to torsades and death. So it is said that when you use methadone at a dose less than 40 milligrams per day, it is safe to use. And you can see there are many medications which can produce torsades when you take it with methadone. So you can see it is divided into some medications which has definite risk, then possible risk, and conditional risk. Some of the antibiotics, the macrolide antibiotics, azithromycin, clarithromycin, erythromycin, then fluoroquinolone, ciprofloxacin, levofloxacin, haloperidol, SSRIs like escitalopram, fluoxetine, sertraline. All these are associated with higher risk of producing tau-SIDA points. And if you look at the conditional risk, there is metoclopramide. And if you look at this medications, most of these medications are used by palliative care fraternity to treat various symptoms. So I already told you, methadone has two indications. One is opioid use disorder, and the other one is for pain management. In India, methadone is available for pain management from 2018 onwards, but it was used as an opioid substitution therapy even before that. So we already talked about the side effects, and let's understand something about pharmacokinetics. The bioavailability of methadone is much higher than that of morphine. It is about 80% bioavailable, and the morphine should not be, or it is practically morphine should not be practically administered sublingually. It should not be administered sublingually because it is not absorbed properly when you administer sublingually. But in case of methadone, it has a good absorption, and even it can be administered rectally. So morphine can be administered through many routes: oral, subcutaneous, IV, parectal, intravenous, intrathecal, many routes. But here, methadone can be administered sublingually, in which morphine cannot be. And the metabolism, which also happens in liver, like morphine. But the importance is that there are various cytochrome enzymes are involved in the metabolism. Okay, so in the let us go back into the absorption. So after absorption, what happens is you can see the methadone will be available in the blood for action for 2 to 4 hours when you administer methadone for the first time. Okay, so for the first 2 to 4 hours, the patient will have some pain relief. But after that, the methadone goes into the tissue binding sites, and they will be mainly binding on tissues in brain, gut, kidney, liver, muscle, lungs, etc. And once these tissue binding sites are saturated, then only the methadone will be liberated into the systemic circulation. So how many days will it take to get saturated these tissue binding sites? It will take about 5 to 7 days. So in normal healthy people, it will take about 5 to 7 days. Okay, so this is the most important thing you have to understand about methadone. So for methadone, the blood level to get stabilized, it will take about 5 to 7 days. But in case of morphine, it will take only up to 24 hours. So you can increase the dose of morphine every 24 hours, but in case of methadone, you have to wait at least 5 to 7 days. So the metabolism, as I told you, it happens in the liver, and there are various cytochrome P enzymes are involved, and because of this, there will be many drug interactions also. So the many of the medications which we use in palliative care can have interaction with methadone. And there are cytochrome P inhibitors as well as cytochrome P inducers. So when you give cytochrome P inhibitors along with methadone, the availability of methadone in the blood will be increased. so that it can produce toxic symptoms. So you can see these are the important cytochrome P inhibitors. Grapefruit. What is grapefruit? Anybody? It is not grape. It is grapefruit, which I think is not available in India. It is like citrus fruit. And protease inhibitors. These protease inhibitors are mainly used to treat patients with HIV. And azole antifungals like fluconazole, ketoconazole, etc. And many of the patients whom we see has cancer or immunocompromised patients, and that's a predisposing factor for oral thrush and esophageal inversion. So one of the important medications which is used in palliative care patients is fluconazole. So that's a cytochrome P inhibitor which can increase the level of methadone. And macrolide antibiotics. So azithromycin, clarithromycin, erythromycin, these all can increase the blood level of methadone. So we have to substitute these antibiotics with some other suitable antibiotics. And amiodarone and non-DHP calcium channel blockers like verapamil and tiazam. These all are cytochrome P inhibitors. So when you use these cytochrome P inhibitors, or when you are going to start a patient on methadone, you have to look for what are the medication this patient is taking and see whether there are any other important cytochrome P inhibitors. And if possible, substitute this medication with something else. And there are cytochrome P inducers which will reduce the level of methadone in the blood. So these are phenytoin, smoking, phenobarbital, oxcarbazepine, rifampicin, carbamazepine, and St. John's wort. St. John's wort is a plant product which is used to treat many symptoms, not in India but outside US and India. So when you use these medications, phenytoin, which is a very common medication which is used by palliative care patients. So another one is oxcarbazepine. So when you use this medication, there will be reduced methadone level in the blood, and sometimes the pain can be increased because of the reduced methadone levels in the blood. And there are a lot of medications which can increase the blood level as well as decrease the blood level. So there is a extensive list. But look here, the tricyclic antidepressants, SSRIs, the azole antifungals, then fluoroquinolones, proton pump inhibitors like pantoprazole, omeprazole, lansoprazole, all those can increase the methadone levels in blood. So for whom we can start methadone, or who are the ideal candidates for starting on methadone? So can anybody tell me what is an adjunct? Anybody? What is an adjunct analgesic?
So that would be a drug that is added in the WHO ladder pain for it can be given either along with the NSAIDs or weak opioids or strong opioids like tricyclic antidepressants, etc., for neuropathic pain and other medications that would control probably nausea, vomiting as well.
Okay, what you have told is right, Mr. But to make it clear, the definition of adjunct is a medication whose primary action is not pain relief, whose primary action is not pain relief, but is helpful in some painful conditions. That's what an adjunct is. So tricyclic antidepressants, the primary action is antidepressant action, but it is helpful in neuropathic pain. Then hyosin-butyl bromide. What is the primary action? It is a smoothness and relaxant. So when you give hyosin-butyl bromide, that will reduce the peristalsis and it will give pain relief if the patient has chronic pain. So those are adjuncts. But if you look at methadone, is it really an adjunct? What do you think? Is morphine an adjunct? Morphine is primarily an analgesic, isn't it? So methadone is also primarily an analgesic. It is not an adjunct. But if you look at the literature, one indication of methadone is as an adjunct. That means it is used along with other opioids in small doses to treat pain. Suppose a patient who is on 20 milligram of morphine for hourly, but this patient has neuropathic pain, which occurs now and then. In such instances, people will add a small amount of methadone along with morphine, maybe 2.5 milligram BD or 1 milligram BD, and that patient will have good pain relief. So, in such condition, when it is used along with other opioids in small doses, it is called as an adjunct. Okay, and you might have seen many patients who are on morphine or fentanyl or any other opioids, and they don't have proper pain relief. And in such condition, that is pain refractory to other opioids, methadone can be tried. And the only orally available strong opioid in India was morphine till methadone was available. And even now, most of the, I think 99% of the palliative care use only morphine. But morphine can be accumulated in patients with chronic kidney disease. So in such situation, methadone can be used because methadone is excreted mainly through bowel, and a small percentage is of course through renal route. But in case of renal impairment, methadone is a choice which you can use. And if the patient needs a long-acting opioid, if the patient has poor compliance, then probably methadone can be used because morphine acts for 4 hours and we usually give it as 4 hourly. But methadone has a longer duration of action. It has 8 to 12 hours of duration of action. So we need to give only twice or thrice per day. So it is a suitable opioid when the patient needs a long-acting opioid. And we already talked about opioid tolerance. So if the patient is taking hundreds of milligrams of morphine equivalent, and in such condition, you may start the patient on a small dose of methadone, and they will have good pain relief. And sometimes opioids can produce hyperalgesia in rare situations, and methadone can also be used to substitute in such situations. And some patients can have severe side effects with opioids, other opioids, with morphine or fentanyl or something, some other opioids. In such situation, use methadone. And I had a patient who was complaining of morphine allergy, and we used methadone in that patient successfully. So these are the indications to use methadone. So it can be used as an adjunct, pain refractory to other opioids if the patient has significant renal impairment, and if the patient has if the patient needs a long-acting opioid, opioid tolerance or opioid-induced hyperalgesia, and poorly controlled opioid adverse effects, and true allergy to other groups of opioids. So there are some inappropriate candidates for whom we should not start methadone. Congenital, there are some people where there is congenital QT syndrome present. And if you get a family history of sudden unexplained death in the family, that may also point towards congenital QT syndrome. So in such patients, we should not start methadone. And if the corrected QT interval, that is QTC, is more than 500 milliseconds, then it's a contraindication. And most importantly, if the patient doesn't have a reliable caregiver, that's also another contraindication. If you administer morphine, the effect is immediate, isn't it? Within 24 hours, we can see what is the effect that is going to be produced. But in case of methadone, you will continue to administer. Suppose you have given an order to give 1 milligram of methadone, but the caregiver mistakenly give 1 ml of methadone, which is 5 milligram. That will get accumulated, and the problems will start after 5 to 7 days, and it will be difficult to reverse also. So it is important that there should be a reliable caregiver when you give methadone to a patient. And if you are unable to follow up the patient, don't give methadone. And it is also not indicated if the patient has acute pain crisis, because we know that it will take about 5 to 7 days to give proper pain relief. So these are the conditions in which we should avoid methadone. So how are we going to monitor the patient if we prescribe methadone? We know that there are some baseline investigation we need to do. These are ECG and electrolytes like potassium, magnesium, and calcium. And if a patient if a patient's goal of care is comfort care, that means this patient doesn't have a chance of curative or palliative oncological intervention, then we need not actually do these investigations, because our goals of care is comfort care. But if the patient is on getting an active treatment, then we should do all the investigations. So that's what I meant by monitoring should be aligned with goals of care. Okay. And if they have a good chance of survival, then we should repeat ECG after 2 weeks. And once the dose of methadone reaches 30 to 40 milligram per day, and then if we increase methadone and if it reaches 100 milligram per day, then we should also repeat ECG. And if we are going to add any other new medications which can increase the QT interval, then that's also an indication to do another ECG. And I told you that it is important to monitor the patient till 5 to 7 days, and because that's the time when the methadone level in the blood stabilizes, so that we can understand whether it is producing any side effects for the patient. So 5 to 7 days, that is for the normal healthy individual. But if the patient is elderly and if the patient has liver problems, then acute liver failure, then we have to wait even more than this. Up to 10 to 14 days it will take to get the blood level stabilized. So in case of normal healthy individual, you can wait for 5 to 7 days. But in case of patients with liver failure, or if the patient is elderly, wait for 10 to 14 days. That's the time taken by the methadone to get the steady state. So these are the two preparations available in India: tablet and syrup. Tablet is 5 milligram, and syrup it is 1 ml containing 5 milligram. Injections are also available, but not in India. As of now, methadone is produced by only one pharmaceuticals in India, that is Rosan, and they produce only syrup as of now. Previously, tablet was available, but now only syrup is available. Now we will move on to conversion to methadone. If the patient is on some other opioids, how will we convert it to methadone? Okay, suppose I ask you, a patient is on 200 milligram of tramadol. What would be the equivalent dose of morphine?
20 mg.
20 mg, because potency is 1/10, isn't it? Suppose the patient is on 400 milligram of tramadol. What's the oral morphine equivalent?
40. 40.
40. It is a linear relation, isn't it? It is always 1/10. But in case of converting to methadone, it is not like that. It has some difference. It doesn't have a linear relationship. So let's see. So look here. So I told you there are various methods for converting an opioid to methadone. This is the latest one, which was brought out by McPherson et al. In 2019. This is a consensus white paper method, and this is very simple method. If the patient is taking less than 60 milligram of oral morphine equivalent per day, you can start 2 to 7.5 milligram of methadone per day. Okay, if the patient is taking less than 60 milligram of oral morphine per day, start with 2 to 7.5 milligram of methadone per day. And if the patient is taking 60 to 199 milligram of oral morphine equivalent per day, and if the patient is less than 65 years old, then the ratio is 10:1. That is 10 milligram of oral morphine equivalent will be 1 milligram of methadone. Suppose the patient is taking 150 milligram of oral morphine. What would be the methadone dose?
15.
It's 15. That is 150 divided by 10. Okay. And if the patient is taking more than 200 milligram of oral morphine equivalent, or the patient is more than 65 years old, the conversion ratio is 20:1. Suppose the patient is taking 1000 milligram of oral morphine equivalent, and he is 75-year-old, and you want to convert it to methadone. What dose would you start?
50.
Yeah, if you calculate, it would be 50. But the recommendation is that whatever be the dose of oral morphine equivalent, you should not start not more than 40 milligram per day. Okay, so that's the first time maximum dose that you are going to start, regardless of the dose of oral morphine equivalent per day. And how do you increase the dose of methadone? I told you, once you start methadone, you have to wait for 5 to 7 days. Then only you can increase the dose of methadone. So if the patient is on less than 30 milligram per day, the permissible dose increase is 5 milligram of methadone. And then you have to wait for another 5 to 7 days before increasing the dose. But if the patient is taking more than 30 milligram per day, you can increase 10 milligram and wait for another 5 to 7 days. So as I told you, If the patient is having normal liver function, then we can wait for 5 to 7 days before increasing the dose of methadone. But if the patient has liver failure or elderly, wait for 10 to 14 days before increasing the dose of methadone. And let's see some of the patient stories now. So this is a 37-year-old man who was diagnosed with carcinoma of the buccal mucosa in 2018. And then he had another second primary, that is papillary carcinoma of the thyroid, for which he underwent a surgery as well as radiation. In 2019, he had a level 2 nodal recurrence, for which he underwent surgery. And the patient then presented to the treating physician with severe pain. So he was describing the pain starting inside the left ear, going to the lateral side of forehead, and then to submental region. It is a pricking type of pain. It's 10 by 10. You can see the pink area here, which is the distribution of mandibular nerve. So they did the extramandibular nerve block. They repeated it twice, but there were no pain relief. So they started the patient with injection morphine, but it produced toxicities, delirium, myoclonus, drowsiness, etc. So they reduced the dose and started on oral morphine. And they put him on oral morphine like this: 10, 15, 10, 30, and 10 milligram SOS. Even with this, the patient had toxicity. When the patient presented to us, the patient was on this much dose of morphine. And they also tried him on various adjuvants without proper pain relief. So these are the medications he was taking: tab morphine, 10, 15, 10, 30 milligram, tab anastrozole, ciprofloxacin, escitalopram, serratiopeptidase, diclofenac patch every day, tab paracetamol 650 milligram anastrozole. So is there any indication to start methadone in this patient? Anybody?
Sir, can you show the drug chart again, sir? The patient is getting.
Can you see?
Yes, sir. So since patient is on morphine and NSAIDs, maybe adjuvants can be tried first, sir.
What advance would you like to try?
Probably amitriptyline.
Okay, actually, I told you they tried the patient on various adjuvants without
Okay.
any
Oh,
pain.
okay. Right. Yes, sir.
Anybody else? Are there any indication to start this patient on methadone?
So the indication of pain being refractory to morphine.
Yeah, that's one thing. And anything else?
There are few responses as morphine toxicity.
Yeah, morphine toxicity. That's another indication. Anything else? Okay. This patient has a neuropathic pain, isn't it? Complex neuropathic pain is another indication to start a patient on methadone. So morphine toxicities and not responding to other opioids. These are the indications to start methadone in this patient. So before starting methadone, what all are you going to assess in this patient?
ECG to rule out QT because he's already on ciprofloxacin.
Yeah, ECG. What else?
Liver function test.
Liver function test. Okay. Okay. Anything else?
whether he'll be available for follow-up and the caregiver thing, because
Yeah.
it's
Yeah, that's an important thing you have to ask. Is there a reliable caregiver? You have to see, isn't it? Okay. Anything else? Anything else you have to ask in history?
So patient is taking escitalopram, so we have to rule out how much is dose the patient is taking, and it may have interaction with methadone.
Yes, you are right. But there are a few questions which we need to ask the patient. One is history of sudden unexplained death in the family. I already told you that congenital QT syndromes run in families, and so we have to ask for history of sudden unexplained death. And another one is there a reliable caregiver with the patient, and you have to take an ECG. And what are the electrolytes that you have to investigate?
Potassium, calcium, magnesium.
Yeah,
calcium, magnesium,
calcium.
and potassium.
Yeah, thank you. So we have to look for calcium, potassium, and magnesium. But I am asking you another question. Do we really need an ECG and electrolytes in this patient? What is the goal of care in this patient? A patient with two primary malignancies and recurred it, and actually the oncologist told they will not be able to do anything from their side. So do we need really the ECG and electrolytes? So this is what I told you. The investigations and the follow-up should be aligned with the goals of care. So if you look at this patient, the goals of care is comfort care. So we need not really do ECG and electrolytes. Okay.
Yeah,
Do
we
you
can
have-
explain the risk and make him understand the risk, and we can give it.
Okay. Yeah. Do you have any concerns with present medications? Anybody has any concerns with these
Yeah,
medications?
the interaction of the medicine can change its efficacy.
Yeah. What all medications do you have problems here?
So ciprofloxacin, escitalopram,
Yeah.
and I think we don't need diclofenac patch when we'll give the methadone if he has a good pain relief.
Okay. What else?
Paracetamol, I think paracetamol can be omitted. Serratiopeptide, see if any demand.
Okay. So ciprofloxacin, escitalopram, that is fluoroquinolones, SSRIs, and the proton pump inhibitors. These are the three medications which should raise some concerns in your mind. Okay. So actually, this patient was started on escitalopram by the other palliative care unit because the patient didn't had pain relief, but the patient did not had any clinical depression. Okay. So okay. So what should be the these are the three medications which we either need to stop or have to find out alternatives. So you are going to start the patient on methadone. So what would be the dose of methadone you are going to start in this patient? What is the dose of methadone?
1.5 to 2.5 milligrams. Sir.
How did you calculate,
1 minute.
Mr.?
This is less than 60 milligrams, I think, per day is
Yeah.
taking. So maybe conversion of oral morphine equivalent less than less than 60 milligram per day. We start at 1 to 2.5 milligram.
Okay. Yeah. Anybody else? What is the total dose of morphine he is taking? Oral morphine equivalent?
65 milligram morphine.
Yeah. Yeah. He is
And
taking
if
65 milligram. Yeah.
and if we are calculating it by the ratio of 10:1, then it will be 6.5 milligram of
Yeah,
methadone.
it is 6.5 milligram. Yeah. Okay. So this patient is taking 65 milligram of oral equivalent of morphine per day, and the patient is 39 years. So the oral morphine is equivalent is between 60 to 199. So the conversion ratio is 1/10. So you can take it as 6.5 milligram. So if you have only tablet with you, start with methadone 2.5 milligram BD, or if you have syrup, maybe 3 milligram BD. But you also need to give morphine as 4-hourly SOS basis, because you know that methadone will take 5 to 7 days to get the blood level stabilized. So that's important. You have to uh, uh, give morphine on a 4-hourly SOS basis. If you prescribe morphine alone for a patient, it will be morphine 10 milligram Q4H and SOS. Here it is not and SOS, it is only Q4-hourly SOS. Okay, that means suppose at 6 a.m. You are going to start a patient on methadone. You gave methadone to the patient and you are asking the patient, do you have pain now? Patient says, no, I don't have pain. You will not give morphine at 6 a.m. But by 10 a.m., if the patient complains of pain, you will give morphine. And 2 p.m. patient says, no, I don't have pain. You will not give morphine. And 6 p.m. patient says, I have pain. Give morphine. And at 6 p.m. you will also give methadone. So that's what 10 milligram Q4H means. So this patient can be started with tab morphine 2.5 milligram BD or syrup methadone 3 milligram BD. Then morphine 10 milligram Q4H and SOS basis. Paracetamol can be continued. And instead of fluoroquinolones, start amoxicillin, which doesn't have interaction with methadone. And you also can give bisoprolol, because methadone is an opioid and it will produce constipation. So you have to continue the stimulant laxative here also. We will move on to another patient story. So this is a 39-year-old woman with carcinoma of the pancreas, stage 4, with liver, lung, and splenic metastasis. So she received 5 cycles of chemotherapy, but because of the progressive disease, the oncologist advised them to stop chemotherapy, and she was advised palliative care. So you can see this is the pain pattern, which starts on the left lateral chest and it radiates to back, and the pain score is varying between 8 to 10. It's a continuous pain. And stabbing pain, movement increases the pain, and the violating factors lying on the right side, as well as she is taking morphine, tramadol, and paracetamol, which will reduce her pain to 8/10 from 10/10. So these are the medications she was on. Tab morphine 20 milligram 6 hourly, injection tramadol 100 milligram IV 8 hourly, injection paracetamol 1 gram 6 hourly IV, gabapentin 100 milligram TIV, amitriptyline 25 milligram HS, bisoprolol 5 milligram 2 HS. So is there any indication to start this patient on methadone?
Yes, an adjuvant opioid with adjuvant we can start.
Okay.
and because she's there, she's only for comfort. Maybe investigations maybe not be very necessary because it's stage 4 and stopped all the other treatment.
Okay, thank you. Any other indications?
Neuropathic component, it's not responding to gabapentin also, even then she has pain.
Okay, yeah. What else?
Patient has myoclonus, so she might have toxicity of morphine.
Yeah.
And non-response morphine also, because while giving the morphine, the scale, the pain score is still 7 to 8.
Those all are indications. Okay. So neuropathic pain, morphine toxicities. What is the dose of methadone here? These are the medications she is on.
6 mg BD, 6 mg BD, sir. 6 mg BD, 12 mg of methadone,
Okay.
120 of morphine. So 60 to 119, less than 65 years age. She's what's her age?
It's 39.
So 1/10. So it will be 12 mg. So 6 milligram BD.
It's morphine 20 milligrams 6 hourly.
It's 80 mg of morphine.
Okay, so 4 milligram. Yeah.
So
Anybody has difference of opinion?
yeah, 40 milligram of 80 milligram of morphine is taken by the patient, and by conversion we can give 8 milligram of methadone. And
I think we have to increase the dose of methadone because she is already getting tramadol also 100 milligrams daily. So conversion of that also is required. So higher dose.
Yeah, you have to also take into account that she is also getting tramadol because that's also an opioid. So that's why I told you it is the oral morphine equivalent. So tramadol you have to convert it into oral morphine equivalent. So you have to consider morphine as well as tramadol. So what would be the dose and the conversion?
We had to add 30 mg of morphine. So 300 mg of tramadol will be 30 mg of morphine. So
Yeah.
80 plus 30, 110. So
Yeah.
11 mg of methadone. So 5.5 mg BD maybe.
Yeah. Okay. So she's taking 80 mg of morphine, but oral morphine equivalent of tramadol is 30. So that will be 110 mg. And as her age is 39 and she's taking oral morphine equivalent between 60 to 199 milligram, the conversion factor is 10:1. So the total dose of methadone required would be 110 by 10. That is 11 milligrams of methadone per day. So you can start either with tab methadone 5 milligram BD or even syrup. That should be enough. Do you have any concerns with these medications?
Maybe, sir, we can omit amitriptyline
Yeah.
because methadone is also having a neuropathic pain. I mean, it can probably help in neuropathic pain component as well.
Yeah, amitriptyline, as I told you, it's something which can produce serotonin syndrome, and also it can increase the blood level of methadone. But the dose of amitriptyline is very less. So even though we have some concern with amitriptyline, you can decide to continue with amitriptyline, or if you are really concerned, you can stop amitriptyline. Okay, so this patient, we started her on tab morphine, tab methadone 5 milligram BD, and morphine 20 milligram on 4 hourly SOS basis. paracetamol, we continued amitriptyline, gabapentin. This patient had very good pain relief for almost 2 months. So these all are the previous two stories were real stories. So we have another patient, 40-year-old man with advanced malignancy of lung with bone metastasis, and he has T12 spinal cord compression. He is complaining of burning pain on both the lower limbs, which is continuous, and its score is 9/10. He is on tab morphine, 40 milligram, 4 hourly. What are the indications to start methadone in this patient?
One is a neuropathic pain, and the other is the pain not relieved with morphine, refractory to morphine.
Yeah. So what would be the dose of methadone you are going to start in this patient?
It's about 200, it's 240. So
Yeah.
1:20, so 12 mg, so 6 mg BD.
Okay. So the total dose of oral morphine equivalent in this patient is 240 milligram. So if the patient is taking more than 200 milligram of oral morphine equivalent per day, or if the patient is more than 65 years old, the conversion ratio is 20:1. So 240 divided by 20, that is 12 milligram of methadone per day. So maybe 6 milligram BD or 4 milligram TID. Okay, so if you want to know more about cytoplasmic interaction or medications which produces QT interval prolongation, these are the sites you can go and download. A few important points from this is methadone is a long-acting opioid which has a duration of action of 8 to 12 hours. But compared to morphine, it will take about 5 to 7 days to get the blood level stabilized. So whenever you increase the dose of morphine, wait for at least 5 to 7 days. But in patients who are elderly, or if the patient has liver failure, better to wait for 10 to 14 days. And whatever be the dose of oral morphine equivalent per day, you should not start more than 40 milligram per day. It is important to see what the medications are patient is, what all medications the patient is taking, and if there are serious interactions, then you have to either stop it or you have to substitute with some other medications. And even though there are various conversion methods available, stick to one method. And I think the 2019 consensus paper, that is white paper consensus method, is the simple method which you can follow, which we follow in our palliative care unit also. Okay, yeah, that's all about methadone. Thank you. Dr. Sunil Kumar.
Excuse me, sir. Sorry, can you please repeat the last sentence? You were saying about some paper which you all are following.
Yeah, I was talking about various conversion methods used for converting an opioid to methadone. So there are many methods available, but the simplest one is the one which I showed you, the white paper consensus method.
Okay, so thank you.
So can I just ask a comment, ask a question in the last patient that you have shown us,
Yeah.
the one with spinal cord compression and neuropathic pain.
Yes.
I was wondering if radiotherapy had been tried, and had failed, and if dexamethasone could have been considered also as a reasonable part of the adjunct treatment before embarking on methadone. Would that be considered reasonable in the context of disease?
Thank you for asking that question. I told you the first two were the real patients, but the third one I just posted here to give you an idea what would be the conversion factor. But I agree with you. Even if I were in the situation, I would send the patient for radiotherapy if the patient had spinal cord compression, and I will also consider that some. Yeah, thank you.
Are there any other questions regarding
Hello, sir. You had
Yeah.
mentioned earlier, some time back, about starting methadone and giving oral morphine SOS as well.
Yeah.
Actually, two of those first two indications were also because of morphine toxicity, and I saw some of the other participants were asking the question whether we can still give morphine, sir, in such situation as an SOS basis, in spite of the patient having toxicity to morphine, sir.
We are not giving full dose of morphine. We are giving it only an SOS basis. So the patient probably doesn't need all the 6 doses. He might need only 2 or 3 doses, because we already saw that for the first 2 to 4 hours after administration of methadone, it will be available in prayer, so that it will give some pain relief. So it is okay to give morphine on a 4-hourly SOS basis.
Sir, is methadone readily available like morphine, or it's only like RMI?
Methadone is available for any institutions with RMI status. So you know that there are 6 ENDs, that is essential narcotic drugs, and methadone is one of that. So if you possess an RMI, you should get methadone.
Excuse me, sir. Is
Yeah.
this tablet methadone, which you showed the picture, is that same one for sublingual application, or is there any other form for sublingual?
No, we have only 2 formulations available, and right now we have only syrup. So that can be administered sublingually. There is no sublingual preparation as such.
Sir, there is a question in the chat asking, one of your prescription had 6th-hourly morphine. So is it best dose 4th-hourly or 6th-hourly?
So is morphine best dose forward? Okay, that was not our prescription. That was the patient sent to us by the oncologist. So that patient was on 20 milligram of morphine 6-hourly. In addition to injection tramadol 100 milligram PID and injection paracetamol 1 gram IV 6-hourly. So you know that morphine is best dosed 4-hourly. So the duration of action of morphine is considered as 4 hours. So you have to give it every 4 hours. And there are some other situations where you will give morphine at a more frequent intervals. Again, Dr. Mrinalini says that was about the first patient whom we talked. Again, that dose was not started by us. It was sent by some other oncologist, and they tried the patient on injection morphine. And I think probably because of the toxicities, they tried on various dose schedules of oral morphine, and probably because the patient had less toxicity with this dosing, they started the patient on that dosing. Dr. Sunil Kumar, why morphine plus tramadol? That's an important question, but we know that that can happen because my mentor, Dr. Rajobar, was talking about. He usually say that maybe doctors who have studied undergraduate or postgraduate for the last 30-40 years have not seen the tablet morphine, and they don't know how to prescribe. So if somebody prescribed morphine along with the tramadol, you can say nothing because they don't know. Nobody teaches them. So that's it.
So there's a question, do we need to admit the patient in the initial 5 to 7 days for monitoring?
Actually, no need to admit the patient. You can start it as an outpatient basis. But if you are going to start methadone for the first time in your life, then I think it would be better for you to admit so that you will have some peace of mind. When we started patient on methadone for the first time, we started with for an inpatient, and we were afraid of starting methadone. I think it was available in 2018 from February onwards, but all throughout the year we started the methadone only for 7 patients. But next year we started for about 20 patients, and then 50 and 100. So that's how, when your confidence increases, you will prescribe methadone. But if you are not confident, then nobody will prescribe methadone. That's the problem.
So what about the cost when compared to morphine? What is the cost of?
Yeah, now the cost of methadone is comparable to morphine. So if the patient is taking high dose of morphine, then if you start that patient on methadone, then the cost which is required for methadone will be less. At lower doses, it is comparable to morphine.
Sir, can you please advise on the use of Ultraset, which has 325 milligrams of paracetamol and 37.5 milligrams of tramadol, both of which are subtherapeutic in their own right, and yet it is so commonly used. I fail to understand. Can you please help on this front? Thank you.
Yeah, thank you, sir. So we know that this combination medications, they have some problems. As you know, sir has already told, it contains only 325 milligram of paracetamol, and you might be giving Ultraset 1 TID, so that the dose of paracetamol for pain relief is not adequate. So this is the problem with the combinations. And tramadol 37.5 milligram. I think in patients who needs fine balance of opioid analgesia, then it would be okay. But otherwise, for patients who require or who have severe pain, it is better to have tramadol and paracetamol separately, so that we can give optimum dose.
Thank you so much, sir, and thank you so much, everyone, for the questions. And as mentioned in the group, today is our last session. So maybe we would like to hear back from you some suggestions for improvement, or is there anything else that we should be doing to deliver the course in a better way? Sripriya, I'm handing over to you for asking feedback.
Thank you. First of all, thank you, Sunil sir, for joining us for the last session. And I believe that, as usual, your sessions has always been very informative, and this was no exception. So now it is an open forum for the entire cohort. We would request you to kindly give us genuine feedbacks, honest feedbacks, whichever you felt was good, whichever you felt could be better, whichever you could, which you feel would have improved. So open to you. Any volunteers to start first? Yes, Dr. Sharon.
Saying thank you.
Sir, where do you work?
I am in Lucknow, sir, at SGPGI, and Pallium India has been funding SGPGI also, and it is an anesthetic-led program. But I'm in radiation, clinical oncology. We practice drugs, radiation, and care all the way through. And my exposure to palliative care was about 35 years ago in Tata Hospital when Julie Byrne came across. This is, we're talking of 1990s, early 1990s. And the Crusaders from UK came. And, and of course, Kerala, of course, was the first stop. And then it also percolated further north to Bombay. And then, of course, the palliative care program started there, and the MD program started there in Tata Hospital, in radiation, in palliative care. So I have groundings from those times. I would just like to say, thank you is a very, very small word. This is phenomenal, what has been addressed. And I am really, I'm at the fag end of my career. And I've been teaching this and practicing this. But what I would say is that I'm really tempted to go into this one-year program just to understand it and, crusade for the cause of palliative care as a part of regular training in oncology. And it's so very heartening, and thank you very much.
Thank you, Dr. Sharlin. Dr. Newster?
Yes, thank you very much, team with ECHO team for this wonderful program of online teaching. So it was very it was an eye opener for me, even though like I'm an anesthetist and I have a little bit of exposure. I mean, I know broadly what palliative care is, but after listening to all these sessions, I understand that there are finer things to it. Like it is something that probably we need to practice it. I mean, in any field we can do it. If you use palliative care principles in what we have learned in this many weeks of our teaching, we can do wonders definitely if we use these palliative care principles. So coming to the sessions, I think all the sessions were exceptionally brilliant, and most prominent were the sessions on communication. So it is something that we lack very much, and probably that would be a foundation for what I would like to practice and learn in these days. And one more thing I would like to add is I think it was an overall great experience, and it was online teaching is difficult for us to go out and have to have practical sessions on site. So having an online program like this, it's definitely very I mean, it definitely gives access to all of us for such an excellent program. Thank you.
Thank you, Dr. Newster. Dr. Mrunalini, over to you.
Hello.
Yes, you are audible.
Yes. I would like to thanks ECO team for the very, as Shaleen sir said, very phenomenal. It was a very phenomenal experience. I would like to share one incident while I was taking these classes on good communication. Then it was very nice class, and I actually tried it with a few patients. And one of my patients, she was a very young girl, about 32 years old, with CA rectum, and it was very difficult for her and her family to convince to get further treatment. But as Dr. Raghavan has told in this class how you should approach and everything, I tried almost all those things, and trust me, though they were convinced and they are taking treatment. And this was a very good experience for me. And plus uh, that's it. I just wanted to share this experience. And also the way we prescribe drugs, morphine, the proper use of morphine, as I'm a radiation oncologist, so we prescribe morphine at our center, and trust me, it has impacted very positively my clinical practice, and I feel really good that I joined this course, and thank you, team.
It is good to know that you started practicing that what you have got from the course. So that's how I hope all of you will integrate these principles into your practice. You need not be a palliative care specialist. As Dr. Newstar told, this can be integrated into any of the medical field. So thank you, Dr. Minal.
Thank you, everyone. I am seeing that comments are flowing in the chat. I'm trying to reply to many of them as far as possible. But rest assured, we are still waiting for some points on improvements, please. If anything, any one point you would like to say that this would have been better, or
I just wanted to know, Sripriya, whether you have already shared the hands-on training option at different institutes where they can go if they want to have a
not yet,
placement.
ma'am, not yet. Not yet
So-
in this cohort.
So while you are thinking for giving constructive feedback, we have collaborated with many centers across the country, almost covering all the states in the country. If any of you would want to go to an institute and to be an observer to see all these practices, all these theories that you have seen putting into practice, you're always welcome to Trivandrum. Anytime, write to us. Let us know when you are planning to come as an observer. How many days would you like to spend with us? We'll be able to show you whatever we have been delivering through the session. But if you are unable to come to Kerala, we'll send a list of training partners into the WhatsApp group. You can choose whichever institute is there nearby to your institute, and you can have an observership for a week or 10 days or 2 weeks, whichever is feasible. That will just add on to your experience, because you have been hearing this virtually. You will be seeing this, and you will get a hands-on experience from institutes. We'll share that list also.
Yes, the list will be shared. Please give me time till tomorrow, because I need to get the updated
problem.
list from the state facilitation team. It will be shared tomorrow. Yes, Dr. Google. Dr. Gurgari, if you are trying to talk, I think you are muted.
Hello?
Yes, sir.
Hello?
Yes,
You're
sir.
you're getting me now.
Yeah. I think your bandwidth is not allowing you to continue smoothly.
Yeah.
You can switch off your video in such a case and continue.
Uh, hello?
Yes,
Yes.
please talk.
Yes, okay. Yeah, so I just want to use this opportunity to say a very big thank you to all the organizers for this training. I think it's been an excellent experience. Before this time, I was really afraid of online classes, online teaching, but this experience has been very awesome. I think I have learned a lot, and from what the previous speaker was saying, I think having an opportunity to get a first-hand on experience in places that are actually practicing the palliative care would be an excellent one. So probably we'll be looking forward to seeing the list of the places that probably some of us will want to go visit and see how it is being practiced. But on the whole, I think the classes, almost all the classes have been excellent. A lot of information we are given. So it's up to us to actually use it as part of our practice. And I think a whole lot of change can be made once we decide to use the palliative care approach to seeing every patient and in our practice. Thank you very much. And to Dr. Manjori for the images, I think it was so much excellent. Each morning I wake up, most of the times I look at those images and I'll just laugh and smile. It would have been actually very much good again if we would have been able to identify people by faces and we get much more interaction. And I hope this group is going to continue. So should any of us run into any problem, you'll always have somewhere you can actually get much more information from. Thank you very much.
Thank you so much, Dr. Gregory. Yes, of course, this group is not going to be freezed or anything. This group will be like this itself, so that you can get in touch with each and everyone whenever you need, whenever you feel the requirement. And yes, Dr. Manjari, amazing. Definitely, personally, I am going to miss those picture series. Yes.
There will be ongoing training programs like refresher courses or specialty-based courses. We do contact every now and then. All the information will be shared in the WhatsApp group whenever we are going to start a new course. So please continue learning together with us. There'll be a lot of courses coming up to update or to keep in touch with the subject or to have meaningful discussions. And anytime if you feel like you need a case discussion in the group, just let us know. We have a telemedicine group also. We'll be able to have discussions with you. So this is not going to be the end of this panel learning. Yeah.
Okay. All right. Okay. Thank you so much.
So in case anyone else is not having any comments, Dr. Sridevi and Dr. Sunil Kumar, with your permission, shall we wind up for the day?
Sure. Maybe wind up for the whole training program this time.
Yes, of course. So only the virtual sessions end with this. And we hope that this is going to be the start of a new journey with a new perspective for each and everyone out there, because through this process, we could understand that most of you were really passionate about carrying on the baton which we are providing you, which we are handing over to you, the passionate palliative care pallium, and wishing that each one of you become very successful in doing that, and wishing everyone out there a wonderful and successful career. Most importantly, a healthy life, safe life. And with that note, positive note, this is Sri Priya along with Dr. Sunil Kumar and Dr. Sridevi Warrior signing off for the last time from the virtual platform. Stay in touch, stay connected, be happy always. Take care. Bye-bye.